So hello and welcome to our talk on transforming transitions from secondary to primary care. So I'm Laura Petchy, I'm a senior occupational therapist at Canterbury and Coastal Community Mental Health Team, and I'm the STROT lead, and I'm with my colleagues.
I'm Celeste Pashley-Hyde, I'm an occupational therapist within the same team, and I support Laura delivering STROT.
My name is Abby Hutter, I'm the clinical lead occupational therapist covering the community mental health teams across the south of Kent, and I've been involved in supporting Laura and Celeste and rolling this out across our other teams. Today we're going to speak to you about a project that we've developed called STROT, which is supporting people being transitioned from secondary to primary care mental health services. So this was developed in Canterbury Community Mental Health Team. This is a team that works with working age adults, people aged between 18 and 65 who have significant episodes of mental ill health. We work with people that have a variety of mental health conditions. This could be schizophrenia, bipolar personality disorder, severe recurrent depression, and we work with people where they require more support than can be delivered within primary care services. We have a wide multidisciplinary team. We have psychiatrists, nurses, occupational therapists, psychotherapists, support workers, vocational specialists, and also we're supported by our admin team. We've noticed in recent years that demand for our service has increased, that we're getting a lot more referrals than we used to do. This has meant that we've had to adapt our approach so that we can use our existing resources to support a greater number of service users and for people to be discharged in primary care when their needs are appropriately met in this area. So a barrier was identified a few years ago where service users had perhaps finished an intervention with a professional who was taking the lead, perhaps a doctor or a psychologist or a nurse in the team, but discharge from services was it either wasn't happening or it wasn't happening successfully for these service users. This might be because staff were concentrating on working with people perhaps who were presenting in a crisis, or when that crisis has reduced, then it's easy for people's attention to return back to somebody else that's perhaps in crisis, and non-urgent pieces of work sometimes don't get, people are unable to prioritise these due to the cases that they're working with. Sometimes service users can feel really anxious and not ready to be discharged from mental health services. And also sometimes service users were being discharged when they were medically fit to be discharged, having completed their intervention, but actually they didn't have the support around them in the community for this to be successful and their recovery to be maintained. So the occupational therapists and STR or support workers within the team that are present in the team, they're working separately, and they came together to develop something that we called STROT. It literally stands for STR and OT. It's STR working and OT is working together to support the team and service users to successfully step down from secondary to primary care services.
So what is STROT intervention? So as Abby's already touched upon, there were a client group identified on existing caseloads who had reached a static point in their recovery. Some of these could be transition successfully independently to access primary care services. However, some required a more personalised approach with practical support to engage with these services. STROT is a short-term structured intervention which is facilitated by a support time recovery worker and an occupational therapist. It is a collaborative intervention between the OT, the STR, the client and their carer if they would like them to be involved, to engage in initial and review assessments, agree goals and devise an ongoing recovery plan. The STR provides the practical support and is overseen by the OT. So the aims of the intervention are to identify a person's needs and barriers to recovery, to be time limited to allow intensive regular therapeutic input. So we tend to offer an initial joint assessment and then 6 sessions with the STR worker. But this can be reviewed with the OT, and there's an option to extend to a maximum of 12 sessions before the discharge appointment. The other aims are to devise a personalised care plan that's achievable, which includes their ongoing recovery in primary care, to enable the person to link into community resources and other agencies, which is an alternative to secondary care, to enable the person to feel confident in their skills to self-manage their ongoing recovery, and support the client with a successful, safe transition back to the GP. The interventions this involves are joint working between the SGRs and OTs, who are experts in building therapeutic rapport to enable participation in meaningful occupations. This also involves setting and reviewing SMART goals, which are based on their personal needs and interests to keep the clients motivated. We utilise grading and adapting as required. We also support with anxiety management, confidence building, addressing social isolation, and implementing strategies. We also look to add daily structure and meaningful activity. We spend our time identifying suitable community groups with practical support to link the people into the groups so they can attend these independently. In February 2020, we had reviewed the statistics and outcomes after a year providing a STROT intervention since January 2019. At that time, we reviewed the 41 STROT cases that had been referred to our team. So 3 of these cases were referred to and assessed with STROT, but had other identified needs from the wider team, so they were not offered the intervention. There were 9 current active cases at that time, and there were 2 on a waiting list for the intervention. 27 patients had completed the intervention and were discharged. 20 of these we had no further contact with secondary services. 7 were discharged and re-referred to the community mental health team. However, 5 of these were discussed at the initial screening assessment and advised to follow discharge plans, so not offered further input with secondary care. And 2 had some further short-term input with the wider team and were then discharged afterwards again. So we found this to be highly successful, and that effectively 25 out of 27 who completed the intervention required no further input with secondary care. As of now, so June 2021, there have been 56 cases through the STROT pathway. We have a waiting list of 9, so it's a total of 65 cases.
So we've reflected on what's gone well and some of the challenges that we've encountered as we've been rolling this programme out. One of the things that's worked really well is having a STROT lead in the team, so that we have an identified clinician, an occupational therapist who coordinates the referrals, and the clinicians matches people up and ensure that we have a flow through that new cases being allocated. We really found that this improved the morale of the clinicians working in the team, that they understood each other's roles better, that they enjoyed working together, there was better team working within the team. And also it was positive for patient flow, that service users were being discharged, that actually that people were moving through the service in a timely manner and not waiting for long periods on caseloads without any intervention. And we received positive feedback from service users and from the team, but particularly the service users felt supported when they were being transitioned over to primary care services. Just some changes and challenges that we've met along the way. So we've developed our eligibility criteria, that we now have a better idea of the type of service users that work well with this kind of intervention. And one thing is that we ask that all other interventions are completed, so that we're not haven't got any outstanding doctor's appointments or other assessments that are due from the team, that all of these are completed so that we can we can keep that consistency and work with people towards discharge. And obviously there are delays where clinicians don't have capacity to complete this work. We're only going to be able to work with people when we've got capacity. We're able to do that. Some clients were not always aware that STROT was a discharge pathway at the initial meeting. It works much smoother. Actually, this has been discussed with their previous clinician. So one thing we've done is we've worked with clinicians so that they really understand what STROT is for, and also we make sure that on our initial letters and things that go out now, we inform people at this point what the STROT pathway is, and that we're aiming for discharge. And out of those, as Laura said, there were 7 clients that were re-referred over that first year. When we looked at them, actually, most of these people had either disengaged with the STROT pathway at some point, or decided that they didn't want to do it. So actually, if people were disengaged, they're much more likely to be re-referred to the team at a later date. So occupational therapy is a part of a group of professions called Allied Health Professions, and we work within NHS England's 2017 plan called AHPs into Action. One of the goals within this is that it supports occupational therapists to support the well-being of our service users, their social and their physical well-being, and helps them to achieve these goals, and also to look at historical boundaries set between services. And this is one of our things that is trying to smooth that transition between services.
So where we are now. So where we created the intervention within the Canterbury team, which was working well and we were proud of, we were encouraged to present that to the senior managers, executive board and the trust board. KMPT has developed clinical care pathways, so the same treatments are delivered across the county, and STROP was consequently adopted into these pathways and is now provided in every community mental health team trust-wide. This involved our service developing training sessions for other community mental health teams, which is still ongoing.
COVID-19 and the impact. COVID-19 affected STROP as it limited face-to-face contact initially, in addition to limiting the services that we could link clients to within the community and primary care. The impact of the pandemic appears to have caused people to feel lower in mood, have increased anxiety around leaving their house and accessing the community. Consequently, the necessity of providing this intervention in mental health services seems even greater than before. I'll discuss two case studies. One is before COVID and one is after. This one is before. A patient was identified from the CPN caseload for STROP to reduce anxiety and link with community services. It was a female, aged 61, with a diagnosis of recurrent depressive disorder, emotionally unstable personality disorder, and physical health issues, had an amputated leg and utilised a wheelchair to mobilise. The barriers to occupations were her social isolation and anxiety around attending groups. Physically, there were 3 flights of stairs to and from her flat, and her shower chair was stuck in an upright position, which caused barriers to accessing the community. A person-centred care plan was devised to provide graded exposure to access her local village and into Canterbury. She received 7 sessions of support, and one she enjoyed and continued to attend independently. STROP liaised with the council to regrade her banding as a priority and referred to the maintenance service to fix the shower chair. The patient was in agreement with transfer of care back to the GP following STROP intervention. Case study B, post-COVID. Patient was identified from the caseload and referred for STROP to engage with community, having isolated himself throughout COVID-19 and having been under our service for a number of years. It's a 58-year-old male with a diagnosis of bipolar disorder, anxiety and previous alcohol dependence. He was employed full-time prior to COVID and commenced his retirement during the coronavirus pandemic. His barriers to occupation included that his face-to-face AA meetings were stopped. There was a risk of returning to drinking after 3 years of sobriety. His retirement started at a time when he was unable to engage in community services. His social network from work and AA were disrupted. A client-centred care plan was devised with the occupational therapist and support time recovery worker. He received 6 sessions of support, where virtual AA sessions were sought and support was given to access these from his home. He now prefers these as he was able to access them globally 24/7. The Recovery College and local community centres were looked at for courses to help structure his day, as he was now retired. On discharge, he hoped to start volunteering in a peer-supported role, helping others with mental health issues or those experiencing alcohol dependency. The patient agreed with the plan to discharge back to his GP following STROP intervention, feeling that he was more equipped now to be without secondary mental health services. Thank you. Questions at all, please contact the STROP lead at laura.petchy@nhs.net. Thank you.
No virtual questions. Any questions from the floor? Can I ask a question? Yeah. I was just going to ask about how you selected your patients to go through the pathway. Was the actual pathway available for all patients, or were you quite selective in the type of people that you actually worked with?
Okay, yeah, no, anyone is available to do the pathway or eligible, but obviously it is a discharge pathway, so if they had some like long-term psychological therapy, they couldn't come into the STROP pathway. But any patient, any diagnosis, they had personality disorder, bipolar, anxiety, depression, so anyone's eligible. But they would refer to myself because I'm the STROP lead. I would look at the patient, see if they have any other identified needs, and sometimes you might say, complete that piece of work, then come back to us, because we're always the kind of ending to transition them back. But anyone's eligible, yeah.
So is this a model that is going to be rolled out across Kent in other areas, or is it just a specific area you work in, or is it?
It started in our, so we created it in our team, and then we presented it to the trust board. So it's now in all the community mental health teams across the KMPT.
Excellent, thank you. Right.
I think we've lost.
I don't know if you're talking to us, but we can't hear anything. So sorry if you expected a response.
I was just saying thank you very much for your presentation. So,
Oh, that's right. No problem.